Hello, and thanks for logging in to today's webinar. My name is Ellen Thomas. I'm one of the speech pathologists and certified auditory verbal therapist at the Cochlear implant program. Today we're going to talk about research that we do here at the University of Michigan and outcomes that we see. Our program's busy. It's a big one, and often patients don't realize how much other type of work goes on behind the scenes outside of patient care. We end up doing research because as we work with patients, we come up with questions and we wonder about things, and then we go looking for answers, and this leads us often to a research project. We're a large team. A lot of times our patients don't realize quite how large, but one of the things that makes this program especially strong is the team collaboration and work that goes on as the collective group. Dr. Alex Arts is our medical director. He is one of the 6 surgeons on the implant team. Dr. Arts and Dr. El Cashlin see both children and adult patients. Doctors Besuros, Dukin, and Tellian see primarily adults, and Dr. Thorne sees exclusively pediatric patients. Our audiologists are vital to our program. We have 8 of them. Dr. Terry Zwollen is the director of our program, and the others all hold either a PhD or a doctorate of audiology. There are 4 of us who are speech-language pathologists and listening spoken language specialists, and we spend the bulk of our time with our youngest patients, helping them and their families as the child learns how to listen and talk. The first study that I'm going to cover today is one that's currently underway. It's sponsored by the Centers for Medicare and Medicaid Services, and it's looking at revised indications for cochlear implants. People don't always realize that what happens in adult research makes its way down to the pediatric population, and this is often how change happens. For this study, there's a target of 90 adults with hearing loss. Currently, 23 adults are enrolled, and it's for people who have hearing that is better than what is currently required by the Medicare guidelines to receive a cochlear implant. This study is using speech perception test scores for words and sentences, and it's looking at this performance before and after cochlear implantation. So the purpose is to evaluate the need for change in the criteria for who is able to get a cochlear implant. It's specifically looking at the Medicare and Medicaid criteria, but third-party payers like Blue Cross often follow suit with Medicare, Medicaid. And it's high time because candidacy criteria for who needs a cochlear implant has not changed since 2005. And for any of us who deal with cell phones or other technology, we know that 12 years is a long time to go without changing something that has to do with technology, given the rate at which progress happens. Many patients come into the program feeling like they're struggling to hear, and they want a cochlear implant, but they don't meet the Medicare criteria of scoring less than 40% on open set recorded sentences. You can see that this is a multi-site grant with 20 sites enrolling subjects. It'll give us a nice overview geographically of the U.S. And the preliminary results are very exciting. In the circle, you see that there were 22 subjects tested preoperatively who scored between 25% and 50% on 3 test measures that are colored orange, blue, and purple. And then you see the data collected at 6 months after activation and 12 months after activation. And we see that there's some really great progress. If you look at the AZ Bio test score in the blue, you'll see that patients went from, on average, 50% correct to 90% correct. And this is an improvement that most anybody would be glad to have on most anything. So the trend so far with the data that's collected to date suggests that there's a need for changes in the criteria for cochlear implants that Medicare and Medicaid use. Based on what we've seen in the subjects to date, they certainly have benefited from a cochlear implant and perform better despite not meeting guidelines preoperatively. Now we'll move to a study that was presented in Washington, D.C. in June. This is one that looks at spoken language outcomes in children who are implanted early. It's important for people to know that our philosophy as a program, and we are an implant program, is that listening and spoken language is the first go-to option that we encourage for families with children who are receiving implants. That does not mean, however, that we don't find times and cases where another option isn't recommended. We have patients who use all of the communication options, and we certainly advocate for whatever best fits that family and that child's situation, and for a choice made by the parents that's an informed choice. This study included 219 children implanted under the age of 5. These were children with unilateral and bilateral cochlear implants. So some had 1, some had 2. They were children with no other known challenge outside of the hearing loss and normal cochlear anatomy. The test scores that we used in this study were from speech and language evaluations and audiology testing, and the children were grouped into 4 groups based on the communication mode that they used. So we wanted to look at the effect of the communication mode on the development and outcomes for spoken language in children who receive an implant under the age of 5. Here are our 4 communication groups. The auditory verbal group is represented in green. You can see the N, or the number of children in that group, was 40. And to be put in that group, they had to have attended more than 25 or more therapy sessions with a certified therapist in the first 12 months after activation of an implant. The oral group included 37 children, and they had to have attended some therapy in our facility. Often they had some therapy during the first year, but less than 25 sessions, or they attended therapy in the 2nd or 3rd year post-implant. The oral 2 group, which was the largest, 77, is a group that was using listening and spoken language as their primary communication mode, but did not attend therapy at this facility, either because it wasn't available, or the family lived too far away, or it simply didn't work in life. The total communication group had 65 children, and these are children who use some degree of both manual communication and oral communication at both home and school. All the groups were equally deaf, But you can see here that the age at which they received an implant was very different. The green bar, the auditory verbal group, received implants at the youngest age, on average 21 months, and there's a stair-step progression up to the total communication group that on average received their implant at 41 months. We know from studies we've done and many others that are in the literature that the age at which a child receives an implant has a direct effect on their spoken language outcomes. And it's understood within the community that receiving an implant prior to the age of 18 months gives the recipient the best prognosis for listening and spoken language. This slide shows the percentage of children who were scoring in the normal range after 3 years of device use in each group. On the left, you'll see the performance for receptive vocabulary or words understood. On the right, we have expressive vocabulary or the words used by the child. The difference is interesting, and on the receptive side, there is a listening component in which the child has to listen and understand the word, where on the expressive side, the child's looking at a picture and has to recall its name. You'll see for both measures, more than 90% of the auditory verbal group were scoring in the normal range when compared to their peers with typical hearing at 3 years of device use. The oral group was scoring between 40 and 45% after 3 years. So this is a group who had some therapy with a certified therapist. And then the blue bar is the group who did not attend therapy at our facility. And you see that they scored lower on the receptive vocabulary side, but higher on the expressive. And then the total communication group has the fewest children within the group scoring within the normal range after 3 years of device use. Articulation is how we produce the sounds of the language. Here we looked at consonant production, and you can see that all 4 groups have a nice trajectory of progress. All 4 made significant progress. Along the horizontal axis, you see the years of device use, so 1, 2, 3, 4. The red line here indicates the typical articulation of a child with typical hearing between the ages of 6 and 7. So 90% of children achieve this level by age 6 or 7. Our 2 groups that received therapy both end up by year 7 scoring a little above the norm, which is not really too surprising given that they've had some intensive one-on-one work with them and their parent. Both of these groups scored statistically better than the other 2 groups. The oral group who did not receive therapy still came up to a pretty good level of about 92% consonants produced correctly, but this is after 7 years of device use. When we look at 4 years of device use, they're around 75%. The total communication group is scoring at around 60% 4 years out, and at 7 years, they're reaching just about 80% of consonants produced correctly. Reading comprehension is always, and reading in general, is a concern for children with hearing loss. And this graph shows the reading comprehension scores at 4, 5, and 6 years of device use. Looking at the groups based on their communication mode. The auditory verbal group scored statistically better than the other 3 groups, and all 3 of the oral groups had performance that was statistically better than the total communication group, and all 3 reached the level that was within the norm. So 100 would be the mean for typically hearing children, but 85 is the low end of the normal range. And we see that there's a slight tendency to float downward in this oral 2 group, but at 6 years of implant use, they are scoring a standard score of 87, which is still in the norm. The percentage of those scoring below 85 was 0 for the auditory verbal group, 30% for the oral group, 24% for the oral 2 group. And then the total communication group, 68% of those children did not score within the normal range for reading comprehension at any of the intervals, 4, 5, or 6 years, and were scoring in the 70s, which would suggest a moderate delay in reading comprehension. In conclusion, we found that children who are implanted early and receive auditory verbal therapy have better spoken language and literacy outcomes than those who use a different communication mode. Children who sign and speak do not tend to achieve as high a level of listening, spoken language, and literacy as those who do not. So we looked at children who had hearing loss as their primary challenge. Now we'll look at a group that is challenging, those children who not only are deaf and receive cochlear implants, but also have a diagnosis of auditory spectrum disorder, or ASD. We surveyed 18 families, or we got 18 responses back from our surveys out of 31 sent, and we surveyed the parents of children with this dual diagnosis of hearing loss and autism. This group is challenging for us to counsel, and often because of the early age of cochlear implantation at around 12, 13, 14 months, autism has not been diagnosed prior to the child receiving a cochlear implant. There are estimates that 1 to 6% of children who are deaf have co-occurring autism. And this means the number of children with profound hearing loss and autism is disproportionately high, which we take into consideration as we counsel families. We ask parents how their child had performed with their cochlear implant based on their expectations. We had 8 responses that the child was performing better than they had expected. 4 families indicated that the child was performing as they had expected. 3 stated that the child was performing poorer than expected. And 2 indicated they really hadn't known what to expect. There is likely some correlation between the expectations of the parents for the child with their cochlear implant and when the child was diagnosed with ASD. Encouraging to us was that when we asked parents if they would recommend an implant to a family who had a child whose situation was similar to theirs, 82% said they would recommend an implant without reservation, and 18% said they would recommend one, but with some reservation. And none of the families said that they would not recommend an implant or that they didn't know what they would do. So this was encouraging and led us to feel that while the definition of success varies, parents of children with autism spectrum disorder and cochlear implants don't regret their decision to pursue an implant for their child, and that parents would recommend implants to other parents with a child who has autism spectrum disorder and hearing loss. Now we'll look at another group. This is the group where we looked at the effect of a second language in the home. Living in southeastern Michigan, we certainly have a number of families for whom English is not the native language, and we end up needing to counsel these families. Conventional wisdom has seemed to be that a family should speak English only to their child with a hearing loss. So to look at this effect, we took 12 matched pairs. So a matched pair was one child from an English-only home matched with one child from a bilingual home that were implanted at the same age, in the same socioeconomic status, and using the same mode of communication. Children with the cochlear implant who lived in a home where English and another language were spoken were the set in the bilingual situation. We looked at test scores from speech and language evaluations and audiologic testing, speech perception testing, to see what the effect of this second language in the home was on the spoken English outcome. So we're really looking at whether or not the presence of this second language affects the development of spoken English in children with implants. We don't have time to review all the data, but this is a slide that looked at words understood or receptive vocabulary after 2 years of device use. And here you see the matched pairs, the yellow bar being children in a bilingual home, and the blue bar being children in a monolingual home. And you can see the performance is pretty varied. But the difference between the blue and the yellow in each pair was not significant. So this suggests that exposure to a second language in the home does not hinder the learning of English for young children with cochlear implants. The factors that affected the success were certainly present, but they weren't the second language. We're part of a multi-center large study called Childhood Development After Cochlear Implantation, or as we refer to it, the CDACI. This study enrolled 188 children, 22 of which are from our program, that were recruited from 6 large centers between November 2002 and December 2004. This study excluded any children who had known cognitive impairments. And it used a variety of parental surveys and a wealth of test data, both in terms of speech perception, speech and language, articulation, academics. So a very comprehensive study. The objective of the study was to compare the children who had undergone cochlear implantation with similarly aged hearing peers across these multiple domains, including oral language, auditory performance, psychosocial concerns, behavioral functioning, and quality of life. And here you see the centers that participate in this grant, Johns Hopkins, House Ear Institute, the University of Miami, the University of Michigan, University of North Carolina, and the University of Texas. This grant has yielded several publications. The most recent and certainly discussed publication came out this spring in Pediatrics and was a study done with this data by Ann Gears and her associates, looking at whether or not the use of sign language, either in the short term or the long term, affected the outcomes of children receiving cochlear implants in terms of their reading. So this is a busy slide, but what you're looking at is reading comprehension after 5 years of device use. And we're looking at the percentage that are delayed. So on the left side, we have children who were not signing. And we're looking at how many of the children in a variety of groups are delayed. When we look at the Michigan study for outcomes based on communication mode, none of our auditory verbal children were delayed in their reading 5 years after device activation. 30% of our children in the oral group were delayed, and 24 in the oral 2 group. The oral being that group that had therapy, and the oral 2 being the group that didn't have therapy. And probably this is not a statistically significant difference. From the CDACI group, 11% of those children in early elementary school that had not been exposed to sign were delayed, and 23% of these children were delayed in late elementary. So we had an increase in the number who were delayed. Now, going to the right side of the screen, we'll look at the percentage of children who were using sign and see what percentage of those children were delayed. So in the group that used sign short term, 19% of those were delayed in early elementary school, but that rose to 54% by late elementary. In the Michigan study, we found that 68% of the children who used sign and were in the total communication group were delayed at 5 years after activation of their device. Now, when Gears looked at the long-term use of signing, she found that 17% of this group were delayed in early elementary, and that rose to 53% in late elementary. So the conclusions that were derived from this study were that it provides the most compelling support yet available in the implant literature for the benefits of spoken language input for promoting verbal development in children implanted by 3 years of age. Contrary to earlier published assertions, there was no advantage to parents' use of sign language either before or after a cochlear implant. So this is information that we take into consideration as we meet new families and are discussing with them and helping them understand options and hopefully leading to an informed choice that fits their family and their situation. We also participate in some clinical trials. Clinical trials are studies that explore whether medical treatment or intervention is safe and effective. This type of study is needed before the FDA will approve a specific intervention or treatment. So it's important work on the forefront that allows others to benefit. This particular clinical trial looks at the safety and efficacy of remote programming of Nucleus cochlear implants. And this is something that would excite many of our patients. especially those that live quite far away. At this point, there are 8 Michigan patients enrolled out of a total of 40 subjects. These subjects have to be native English speakers and have received one of these Nucleus devices, and these are the internal device numbers. The data that is looked at in this study is comparing the results of live mapping in the clinic versus mapping that was facilitated through telehealth type practice in a remote, where the patient is in a remote location, and the maps that were derived when the patient was unassisted in a remote location. And so they looked at the maps in these various situations and also at word recognition scores. In addition, the patients were given a satisfaction survey to fill out to provide us with insight into their feelings about this type of programming. The study is really looking to satisfy the question of whether this is a safe way to program individuals and whether it is effective. We certainly don't want to do something that we think is going to be easier for the patient and have it turn out to lead to poor performance. The data has been collected but not yet published, so we don't yet know the results of that study, but I think the general feel is that it was positive. Another clinical trial that we're participating in with Cochlear is the Nucleus 532 study. So this is 532 is the internal implant, and for this study it is paired with the latest sound processor, which is the N7. This study is currently enrolling patients. The target is 100 adult patients. We currently have 3 patients from our facility enrolled. They have to be adults who are native English speakers, and they have to be candidates for conventional cochlear implant, meaning that their anatomy is not abnormal. For this study, the surgeon completes a questionnaire about the surgery itself, and then the patient participates in a very rigorous battery, both pre and post-op, of speech perception testing and hearing testing. The post-op intervals are at 1, 3, and 6 months. So these patients have to be willing to spend some time in the clinic. The purpose is to investigate the clinical benefit for patients implanted with the Nucleus CI 532 and to demonstrate the atraumatic nature of the electrode design. And this idea of atraumatic is important in terms of preserving any residual hearing. The exciting thing in terms of the external processor, first and foremost, from my opinion, is that finally somebody developed a Find My Processor app for the iPhone so that a parent can find their child's processor when it falls off in the sandbox. But also, this device will allow a patient to adjust their settings using an Apple device and also give them information about their use and battery consumption on the iPhone platform. So it's an exciting thing, and participating in this kind of research allows our patients access to sort of the forefront of where things are and helps us be better informed about what option is potentially the best for a particular individual. We participate in research hopefully with the end result that our patients benefit and are more successful and more satisfied with the outcomes that they see. Thank you for joining me today, and we appreciate your participation in these webinars. They're sponsored through our Sound Support Grant, which is a matching grant funded 50% by our Department of Otolaryngology and 50% by Michigan Medicaid. We feel extremely fortunate to have the grant and hope that you'll be able to participate in additional events or webinars that we conduct through the grant. Thank you.